But you don't see my face. How do I get it to I did, but it doesn't. Look, this is what I didn't have to. That's the image you sent. So no, I think that's the only one. We have to see a bunch of crap, same stuff. Go back. Oh. Oh my god. Oh, I got it. I think yes. I think it's right. Oh, like that. You have another Gmail? I'll record it the old-fashioned way, okay? Then I'll figure it out. Get out of here. Okay. Very close. Figure it out in the background. Get out of here. Okay. Let me pull up the. Let me pull up the. Okay. Okay. So we're gonna start with the. Can you see it? Can you see it? We'll start Dr. Sun's lecture. So we're gonna talk today. We have to start and finish traumatic disease. Is my goal. And then tomorrow we can do. I think I have like three presentations of pediatrics. The next week I want to finish pediatrics so that we have one day for the review. Okay. So the exam is on. Oh, right. So, oh, wait, what? So what? So how not return? Okay, so we'll start with the These are pretty straightforward. So this is one of my favorite lectures. Not the overall. This is a good topic. So I even have a video that I'm going to show you guys as well that will kind of help you with understanding what the will give you an idea of what complications you will see in patients with hepatic disease, and it kind of will kind of make sense once we go through that video. So for Dr. Sun's lecture, focus on. So I went over the lecture last night, and I kind of wrote a couple things that I thought were important for you guys to remember. So I'll just focus on that, and then we can move on to Dr. Wanson's lecture. Okay. So the first thing is the function of the liver function. So what does the liver do? Obviously, focus on whatever he highlights or he circles. That's pretty important. You've had exams, where Dr. Sun is the one writing the questions. So make sure that you understand all of these things. It makes sense. It should make sense at this point. Focus on the synthesis of plasma protein, even though it's not highlighted there. Understand what that means. Obviously, when you have low albumin, that's an indicator of hepatic disease, or it could also be malnutrition, right? So those are the two main things where albumin usually goes low. The other thing is the clotting factors, because the liver makes both clotting factors and also albumin. So that's why later on you will see that they're both part of your Child-Pugh score for staging purposes. Okay, so that's why that's important. In addition to that, he kind of focuses on the medchem aspect of it. So he's focusing on the detox and activation of various substances, and we'll go through that as well. You know that metabolism happens in the liver, phase 1 and phase 2 reactions. So that's why it's an important organ. In addition to that, formation and secretion of bile. So it's responsible for, remember that bile is a byproduct from cholesterol, and the liver plays a very important part in the production of bile. And then in addition to that, nutrient vitamin metabolism. And then they also put here immune system Kupffer cells. Those are the cells that have immune activity against foreign substances. But focus for the purpose of this presentation on the detox of and inactivation of various substances. So this slide, I'll actually, with the video, you will be able to understand it a little bit better. But just know that there are a lot of different vessels that are connected with the liver. They're very important vessels. The aorta, for example, the inferior vena cava, and you will see also the portal venous system as well. So we'll go through that when we see the video. It will make a lot more sense. So as far as the cytochrome P450, we know what these are at this point in time. The ones that he highlighted are the most common ones. So you should know these by now. So CYP1A1, 1A2, CYP2C9 specifically, CYP2D6, CYP3A4, 3A5, and then also remember, even though he didn't highlight it, CYP2C19, because that's pretty important as well for both clopidogrel and the PPIs. And then there are other reactions that take place, like glucuronidation, sulfation, which are more phase 2 reactions, right? For clinical significance, this is pretty important. So whatever he highlights is what I would kind of focus on. In cirrhosis, CYP enzymes or CYP levels can be diminished, which makes sense, which is why you will have an increase in your byproducts, right? Because your liver is not detoxifying. And that's one of the things that the liver is supposed to be doing. When you have cirrhosis, you have scarring of the tissue. What that means is that you're killing the cells that are responsible for detoxifying some of these toxins. And so a good example of that would be hepatic encephalopathy. So hepatic encephalopathy, the reason why you get that is because you have an increased level of ammonia, right? That's one of the hypotheses that explains why patients with cirrhosis develop hepatic encephalopathy. And the reason for that is because of a reduced CYP level and overall phase 2 metabolism. So very challenged. I don't even know what that means, but just know that this slide kind of talks about the narrow therapeutic index. Try if you can to memorize this here. He may have a question about therapeutic index and how it's calculated. It may be may not be an actual calculation, but more as a conceptual question. So make sure that you kind of understand what's going on here with regards to the therapeutic index. PK/PD, I think we can skip this. We pretty much are very familiar with these two concepts at this point in time. So we can move forward. This, I wrote down here. Oh, I didn't write anything down. AUCs and half-lives at this point, again, he's not going to focus much on this. He's going to focus a lot on the drugs that he presented on the slide set. So we're gonna go through all of them one by one. All of these things are pretty straightforward as well. Drug-induced liver injury, which is also known as DILI, is again it's liver damage. Usually it's acute that has been induced by a drug. Could also be chronic as well. The biggest one is acetaminophen. We'll talk about that as well later on. Isoniazid is another one that you should know at this point. Phenytoin, valproic acid, erythromycin. So we'll go through all of them one by one. So for the risk factors of liver injury, you have environmental risk factors. You have genetic risk factors. So look at the different environmental risk factors you can have. Under environmental risk factors, you have your drug-drug interaction. So that's where the drugs will fall under. And then you also have age-related changes in pharmacokinetics there. You also have pre-existing liver disease. So they're all pretty straightforward. The other thing that I would pinpoint here is the impaired antioxidant defense. So one of the biggest things that you need to remember is the glutathione, which is basically your antioxidant that is responsible for making sure that there is not an increase in reactive oxidative species or ROS. So when you deplete glutathione, that's when you have liver damage or issues with or an increase in oxidative states. So that's something that I would remember. In addition to that, you could also have liver damage due to an infection, and you should know by now, hepatitis B, hepatitis C could eventually predispose you to liver disease. And that's pretty much it with regards to this particular slide. And you also have two different ones. You have the acute and you also have the chronic, just like with renal. You can have acute renal failure and chronic renal failure. So same thing goes with this one. All of these slides, I tried to make sense of them and I wasn't able to. I'm not sure why he had them there. Did he talk to you guys about these medications at all? Because it seems like they may contribute to hepatic disease or hepatotoxicity, but not all of them do. So I wasn't sure, like for example, antihyperlipidemic drugs, why isn't simvastatin there? Even though that's the one with the most toxicity from all the statins. So I would just skip all of these slides because I don't think they're important. I would focus on the list that he provided. He actually provided this list twice, so that's what I would focus on. So drug effects on the liver, you have inducers and you have inhibitors. You know this by now. For the inducers, you should kind of associate that with most of your anticonvulsant medications, phenytoin, your phenobarb, and then also your recreational drugs like ethanol and cigarette smoking. And then rifampin, which we use for what? What is rifampin used for? Tuberculosis, very good. And you also can use it for endocarditis if it's prostatic damage, right? So that you can penetrate for that. But good. So rifampin is also a pretty potent inducer as well. So they can have an effect on the liver. So that's pretty much what you need to know from that slide. Okay, so this is another slide that may not make sense because it's not in order. I think the presentation is just all over the place, but this slide pretty much tells you the importance of albumin concentration. So basically what it says is that when you have a normal level of albumin, which is around, what's the number that we're looking for albumin? 4, good. So the 4 would be a normal range for albumin. So then you would have that one to your right, or to your left rather, where you have a free drug, but you also have drug that's bound to albumin. Now, when albumin goes down, what do you think happens to the drug? You have more unbound drug in your circulatory system. That's pretty much what it's showing here with this slide. So it is important. It is applicable to liver disease because remember that the liver is the one that's producing or making the albumin. So that's why. From this slide, what's important I would highlight is where it says until 1 year, liver function is still immature. So that's very important because you want to remember, this is why most of the drugs, for the most part, they have a cutoff value of 2 years or higher. You could see certain drugs that have a 6 months or up, but for the most part, 2 years or older you because of this, the liver is immature at that point, so the liver is not able to detoxify the drugs or the metabolites as it should. So the kid is predisposed to um, toxicities. So that's one thing that I wouldn't know. And then the other thing is between 1 to 12. So memorize those numbers as well. 1 to 12, there's an increased activity of metabolizing enzymes. Okay, that's important for later, which is why we'll talk about the different cutoff values for acetaminophen as well. You want to know the cutoff values for children, which is about 7 to 10 grams, and then for adults. That will, predispose you to acute renal failure. Okay, but know this: after 12 years old, the liver pretty much works the same throughout adulthood as well. Okay, and then it starts to decline just like everything else as you age. Unfortunately. Okay, so for acetaminophen is the first one. A single dose of 10 to 15, so it's a higher dose for adults, produces liver injury, and 25 grams is fatal. We typically tell patients 4 grams, right, is the max. If the patient has liver damage, then you want to say 3 grams instead, but that's controversial. The important thing about acetaminophen is that it's very commonly used as an over-the-counter product, but you do have a reversal agent. So what do you know what the reversal agent for acetaminophen overdose is? I think have you guys covered toxicology already or not? Okay. So NAC, so N-acetylcysteine, which is the brand is Mucomyst, which also very interesting is also used for breaking down the phlegm for patients that have like COPD. A lot of people you're going to see it Mucomyst order for respiratory therapy for that purpose as well because it's a surfactant. But basically, an N-acetylcysteine is a precursor for glutathione. That's basically what it's doing. So I am replenishing the glutathione level so that the toxicity of acetaminophen goes down. Because remember that I said glutathione is the one responsible for kind of counteracting or balancing out the reactive oxidative species that are coming from metabolism, right? So acetaminophen, the problem with acetaminophen is that at high doses, so between 10 to 15 grams, there are two different metabolic pathways that it goes through. Okay, at higher doses, it goes through a metabolic pathway that produces a reactive, an ROS, pretty much, which is called NAPQI, okay, or NAPQI. And so glutathione, initially you have enough glutathione to kind of hold off a little bit, but then you will deplete your glutathione reserves, right? So that's when acetaminophen becomes an issue with the liver because you don't have glutathione. Okay, and so that's when you can use N-acetylcysteine to replenish your glutathione reserves. Okay, so that's just the way it works. And I think it's important to remember not only for this presentation, but also for toxicology when you see it as well. What do you mean? Yeah. And what was the... Oh, yeah. So they do. So they have to do it within 30, and you'll see later on within 30 minutes. Um, C is the last bullet point says neither of these agents is effective if given greater than 30 minutes. So they actually do a loading dose and then they do another dose and they look at the trend of the acetaminophen, the metabolite. So I'm not sure if that's what the journal club is referring to as far as like giving it 2 times or 3 times, but I know that for a fact you give it a loading dose first within 30 minutes, and that's very, very important to remember. And then after that, you want to give it again depending on the level of the NAPQI. The other treatment options that you should know is gastric lavage, supportive measures, and oral activated charcoal or cholestyramine. Okay, this is very important also for toxicology. Charcoal will pretty much bind to whatever is there, okay, and then you will excrete it, just like cholestyramine. You will excrete it in your feces. So that's pretty much it. It's just a binding agent. And then gastric lavage is just cleaning that, your GI. Okay. So we talked about N-acetylcysteine reduces the severity of hepatic necrosis. Again, therapy should begin within 8 hours of ingestion, but may be effective after 24 to 36 hours. I'm sorry, I said it wrong. So for all the agents that we talked about, for the cholestyramine, the charcoal, and the gastric lavage, that has to be within 30 minutes. Now, for acetaminophen, though, it has to be within 8 hours. is the those numbers though I would memorize because they may ask you those questions on the exam. So those numbers I would highlight, and then how effective it'll be between 24, so a day or two at the most. So N-acetylcysteine comes in an IV formulation as well, so that's also something to remember. This is the metabolism of acetaminophen, and this is what I was talking about earlier. There are two different pathways. You can either go through the sulfation or glucuronidation pathway for acetaminophen, or see, you have glucuronidation here, and then you have sulfation here. But then in the middle, this is where the NAPQI forms, and that's at higher doses. Okay, so that, like I said, between 10 to 15 grams for adults, that's when it starts to form, and then you would need glutathione to kind of balance it out. So halothane is the other drug. This, do you know what this is used for? The halothane? Yeah, perfect. Yes. So exactly, it'll knock you out. So it's an inhaled anesthetic. It's a very powerful one. It's an idiosyncratic hepatotoxic inhaled anesthetic. So just know what it is. And then the other thing that I would highlight is this right here. It is not a direct hepatotoxin, but rather a sensitizing agent, meaning that the mechanism of action by which the hepatotoxicity comes into play is not a direct association, but it's just it sensitizes the liver to cause toxicity. Acetaminophen is an example of a direct hepatotoxin, okay, because you have the active metabolite that will cause necrosis of the liver in a direct way. So halothane, I would know that. And then the other thing that I highlighted here, here's then you're so the other thing is, okay, so halothane, the second bullet point. So patients with delayed spiking fever or jaundice. Do you guys know? You guys know what jaundice is, right? So that's one of the indications for when you have liver disease. Um, so after halothane, should not receive it again. That's very, very important to remember. That second bullet point from the halothane slide. Isoniazid is a medication that's used for tuberculosis. Is very commonly used, part of the RIPE therapy. Remember that. Um, just know that it is very rare, but it is very severe, the hepatotoxicity that's associated with isoniazid. Okay, it is enhanced by, look at these three things: alcohol, rifampin, and pyrazinamide. So out of all three of these three options that will increase your hepatotoxicity, two of these are already part of RIPE. So by itself, when you have a patient that has tuberculosis, they have a really high risk of developing hepatotoxicity. Okay, because all of these drugs will be given together. Okay, so just remember that. Sodium valproate. So what is sodium valproate used for? Seizures, migraines, and then bipolar disorders, some other disorders, mental issues, that sort of thing. Remember, very important with so valproic acid is that predominantly happens in children. Okay, that's very, very important. And I guess it has to do with the fact that we use valproic acid to treat seizures in children more so than phenytoin, because phenytoin can cause osteomalacia and other growth issues, like developmental issues. So they kind of try to stay away from phenytoin. They focus on sodium, on valproic acid. So that may be the reason why it's predominantly in children, but just know that it affects children more than it affects adults. In addition to that, very important is that valproic acid is a lipophilic drug, so it will affect the lipid oxidation process. Okay, and we'll go through that as well later on. Keep in mind that your liver is very closely associated with fat distribution and also fat metabolism. That's extremely important. And it's very connected to your bile duct is actually right next to your liver. So when you have a problem with your bile, you will probably have a problem with the liver as well. Okay, so just make those associations, and we'll see that video that will help you understand that a little bit better. It may be ameliorated by IV carnitine, which valproate therapy depletes. Now, pay attention to that one last bullet point. IV carnitine. So carnitine is an amino acid derivative, and it's used for fat metabolism. So when you have valproic acid, the problem with valproic acid is that it goes straight into to the cell, into your nucleus, because it's a fat soluble drug, right? And then it goes to the mitochondria, and it affects the fat metabolism by depleting this carnitine. It's actually an enzyme, but it basically depletes carnitine. So by depleting carnitine, what happens is that your fat metabolism no longer happens. Is what happens. And so by giving IV carnitine, you are replacing your endogenous carnitine, and therefore you are protecting from liver damage. It's exactly is what you need to think about. When you go through the toxicology lecture, IV carnitine is one of the things that you actually give for valproic acid overdose. Okay, so just remember that. No, you don't. So you keep it. Yeah. So by keeping the fat or having a bad distribution of fat, what happens is that you're not excreting it appropriately through the bile, then you can get cholestasis, which is bile duct obstruction. By getting cholestasis, you eventually get a backup of flow going to the liver, and then you can get liver disease. Okay, so that's kind of like the thought process. It's just fat is not metabolized the way it should, because you need carnitine for that. Okay. Um, the next one is phenytoin. Phenytoin, we've talked about it. Remember, that's an enzyme inducer, so that's important to remember. And then also, you can see that ALPs and ASTs and are going to be elevated when you use phenytoin within the first 2 months of therapy. So that's important to remember as well. Amiodarone, we use it for what? For arrhythmias, also like AFib, for example, specifically AFib, we use it. The one thing that I would memorize from this slide is that it has a very, very long half-life. So long that I think after even 3 months of discontinuing the therapy, you still have enough amiodarone in your system. It's 107 days your half-life. So it's important to remember that because amiodarone interacts with a lot of drugs. So unfortunately, I don't think that there's a drug that can reverse the effects of amiodarone that quickly. Again, because of a long half-life, and the volume. It really is just the volume of distribution. It distributes to a lot of places, so that it has a high volume distribution. But just know that from that slide. Erythromycin. So erythromycin, what I would know is that it causes cholestatic blockage due to, and this is more of a formulation issue, due to the formulation that erythromycin comes into. So that's something that I would kind of remember is because of formulation that erythromycin is available in, that you eventually develop cholestasis. So cholestasis, again, is just the blockage of your bile duct that will eventually affect your liver as well. Oral contraceptives. So oral contraceptives, what's important is that, again, it causes cholestasis, so that it impairs the flow of bile. Okay. In addition to that, you will see later on when we go over complications of cirrhosis, and this is just something so that you can start getting your thinking hat on. When you have issue with cholesterol, bile, really, bile is not being excreted appropriately, right? Bile is composed of what? Bile. Like, what is bile? So it's cholesterol, right? Because cholesterol is one of those molecules that you can't really metabolize. You can't break down. So what happens is that cholesterol you actually convert into other things. Bile is one of those things that you convert. What was that? BLD? Yes, exactly. BLDL, correct. And bilirubin is another thing that would, like um, bilirubin is really bile that cholesterol converts to. When you have issues with cholesterol, not you have a imbalance in your cholesterol metabolism. What do you think happens as far as hormonal changes are concerned? You have an issue, an imbalance with your cholesterol. So think about sex. Uh, think about sex. Hormonal. So it goes down. Yeah, it goes down. Your testosterone goes down because your testosterone is coming from cholesterol. Is a cholesterol derivative. So then you develop gynecomastia. So that's one of the things that you also want to remember as well. Eventually, because when we go over complications, especially ascites, there's one drug that you use for ascites control, and that's your spironolactone. And you already know that spironolactone will also cause gynecomastia as well. Okay, so just think about those things while we go through the lectures. Bactrim can cause. We know this as well, and just know the last bullet point that is the sulfonatoxical component, and now the trimethoprim that causes the hepatotoxicity. And again, it has to do with, remember how the mechanism of action of Bactrim. What is the mechanism of action of Bactrim? You guys remember? So you have two different drugs with different pathways. But what's the main thing? What's the most important concept for it does? Correct. Very good. Okay. So what are you what particular, I guess, chemical structure component rather is your block? Yes, you're right. You block two enzymes rather, because you're blocking it early on. That's why you have the trimethoprim Bactrim or sulfonatoxazole. Um, but what is it that you're inhibiting? The production of what? So what do you give to pregnant patients? Yes, so folic acid, right? Correct. So it blocks so it inhibits the production of folic acid. Okay. Eventually, by doing so, it could lead to hepatotoxicity as well. Okay. But just know that Bactrim is very potent hepatotoxic drug to the point where you have to counsel patients on not taking alcohol, not drinking alcohol while you're on Bactrim. Okay. Very good. This slide I would completely skip. I don't think it's necessary to know. And then he goes on to hepatic encephalopathy, which we'll cover later on in more detail, so we can skip this as well. I went through all of these slides, and he doesn't have anything that Dr. Wampa doesn't have in her lectures, so we can skip it. Yeah, we can skip all of these. Treatment, yeah, there's nothing here. Portal hypertension and cirrhosis and drug metabolism. So focus more on the medchem aspect of it. Just know that, look at the example that he has. There's a twofold increase in bioavailability of propranolol in cirrhosis compared to normal. Because remember that the beta blockers, they go through usually CYP2D6 or even 3A4, and because you have less CYP enzyme activity when you have cirrhosis, your active drug is still going to stay in your body a lot longer, so your half-life is actually longer, right, when you have a cirrhotic patient. So which is pretty straightforward, but I would know the things that he highlights, so that particular example with propranolol, I would try to memorize. And then he goes over the DILI, which we talked about. So all these are more statistics. I would kind of skip this. It's not that important. From this slide, what I do not understand the design of the slide, but what I can tell you is that looking at the drug classes, just remember your pioglitazone, Avandia, Actos, the TZDs. TZDs will affect it goes into your nuclear transcription phase, so it will cause hepatotoxicity as well. So all three of these can cause hepatotoxicity more than the I guess than other diabetic drugs. And then these two are very important. So what are these? Solindac and diclofenac. What are the drug classes? NSAIDs, very good. But they're very compared to, and I guess it's comparing aspirin to these. Comparing it to aspirin, these are actually very hepatotoxic. So just know from this slide, what I would know is, because I don't think that we have troglitazone actually available here in the United States, so I wouldn't really care about that. But from this slide, I would know though the diclofenac and Solindac, that they are very hepatotoxic compared to the rest, like the ibuprofen, naproxen, and aspirin, and so forth. These are very straightforward, so we can skip it. This I will also skip because it talks about, again, how the ROS will develop, and again, it's because of the depletion of glutathione. That's pretty much it. That's just as straightforward as it'll be. And then from here, it's showing you the different phases, and you already know this. Phase 1, you're making it more polar. Phase 2, you're attaching something to it to excrete it, okay? So for your phase 1, as you can see, most of the drugs will have a hydroxy attached to it, so you can make it more polar. Phase 2, you actually have a conjugate. So it could be sulfa, it could be a glucuronidation, and that sort of thing. So that's what they're talking about. And you can see the glutathione is actually one of those conjugates as well. Okay, so phase two is what ROS should go through to be inactivated for you. So that's the only thing that I would focus on in this slide. And then we can skip all of this. This is redundant. Okay, so from this slide, I did have something that I wrote down. Okay, so from this slide, oh, it's not this slide. No, I don't have anything on this slide. So from this slide, you should focus on the drugs that he talked about. So isoniazid is there, and then what is the type of reaction? So that's what I would try to memorize. Hepatocellular reaction, isoniazid, autoimmune, with one of these nitrofurantoin, lovastatin, that sort of thing. I would actually focus on the ones that he presented. So autoimmune and steatohepatitis, which is basically less like a bile buildup. Amiodarone is the one that I would memorize. From hepatocellular is isoniazid. So these are all the types of reactions that the drug actually it takes place for the drug to be hepatotoxic. It's pretty much what he's referring to. And then this slide. Oh, the other thing that's very important is that one of the things that happens with when you have a drug that's hepatotoxic is that there's impaired mitochondria function, which we already knew, right? Because that's why you have lower fat metabolism. Okay, most of these drugs can go straight to the mitochondria, like valproic acid, for example, and then it will disturb the fat metabolism. And so just remember that one of the pathways of hepatotoxicity is impaired mitochondria. Okay, that's important. Then this right here, the last one, is the one that, even though he highlighted this one is pretty straightforward, but the last one is very important. Fatal valproic hepatotoxicity may occur with greater frequency in children under the age of 2 who are receiving multiple drug therapies. Now it makes sense to you because we talked about the first year of life, the liver is immature still, so it's not able to detoxify the toxins from the drugs, right? So that's why valproic acid is fatal in those children under 2. But in addition to that, we talked about valproic acid being used, very commonly used in children, more than the other drugs. This we can skip. Yeah, this is what I was talking about earlier as far as valproic acid being a lipid drug, a lipophilic drug, and it goes straight to the mitochondria and it inhibits FAO, which is fatty acid oxidation. Okay, so that's what's happening. You have a fatty acid buildup, and then everything will make sense once we go through the complications, the clinical complications of cirrhosis. But just pay attention to the fatty acid oxidation, inhibition of that. And then mitochondria. So this is mitochondria. So like I said, valproic acid would go into the mitochondria and will disturb the process of fatty acid oxidation. We talked about the isoniazid, rifampin, and PZA being potentially hepatotoxic, and together the risk is actually higher. So now, one thing that's important to remember is that ethambutol is the last part of the right therapy for tuberculosis, right? But ethambutol is not associated with hepatotoxicity. So that's what I would know that. So of all the right drugs, R, I, and P are the ones that are associated with hepatotoxicity, but not E. E is associated with something that's very particular. Do you guys remember the side effect that ethambutol is known for? The side effect that ethambutol is known for? Yeah, so it starts with an E, so it's eyes. That's the way I remember. So it's visual disturbances. It can eat your eyes as well. So if you have issues as you go along through the therapy with your eyes, then they actually stop with ethambutol right away. It's so annoying. Just I don't know how to do that. think I don't know if it. No, still on Spanish. But I can't read them though. Now I think I stopped it too. No, that's okay. Maybe focus is full. Um, I can start it again. Like, no, it's not it. Whatever. Create. I'm gonna create a new one. What? I don't even know if I can. Is it on your audio? I don't know. Whatever. I'll create a new one now. 'Cause I don't know how to do that. I'm trying to see. Alex. Ugh. I hate you. I don't even know how to do it. How to do it. Create. Tell him that he's now he's not getting anything. Anyway, let's keep going. What is it about? Oh, here it is. Oh, here it is. My bad. Cancel this. Oh, is that it? Yeah, this one. Well, I already adjusted it to here. So can you hear me better? I don't know if you can still hear me. Okay. Anyways, in the meantime, let me pull up the. I apologize. Okay, so we talked about the ripe therapy, and again, we talked about the ethambutol not being hepatotoxic, so we can skip that. And then he goes into more detail as far as these drugs that are anti-tuberculosis drugs. Again, what I would memorize is the that the combination will increase the risk of hepatotoxicity. At this point, there's nothing else that you can focus on. We know that rifampin is one of those potent inducers as well, so it's part of this. And then isoniazid-induced hepatotoxicity is considered idiosyncratic, which means that you guys know what that means. Yeah, we don't know why, but it is associated with hepatotoxicity. So there's no direct association like acetaminophen is not idiosyncratic, but isoniazid is. So make sure that you remember that. You have a Yeah, and what they do is they actually stop. Remember that you can always give isoniazid with PCA by itself, or with rifampin. I'm sorry, by itself. So you can kind of get rid of the PCA, so you're getting rid of at least one drug. Sometimes they even space it out, so they don't give you like the full doses. They may give you like half doses, and then longer periods of time. But they kind of work with that. There's not a lot of drugs for tuberculosis, unfortunately. So there are other drugs that are under the rifabutin. Like rifabutin, for example, has a less hepatotoxic profile. So then you could use rifabutin instead of rifampin or rifapentine, if you remember rifapentine as well. So those are alternative options for a patient that has tuberculosis and cirrhosis as well. And then the last part is antiretrovirals. So just remember the class. So nevirapine is associated, it's an NNRTI. It's the only one that is associated with a hepatotoxicity, okay, very high hepatotoxicity. So I would remember that. Most of your PIs, so do you guys remember the PIs, the protease inhibitors? Okay, so for example, ritonavir, lopinavir, very good, indinavir. So all those are protease inhibitors, and they are associated with hepatotoxicity as well as your NRTIs. An example of NRTI would be so bacavir, exactly. And then tenofovir would be another one, and trosidazine. Very good. So those three, I would remember the NRTIs, the PIs, and the nevirapine, which is the only NNRTI that is associated with hepatotoxicity. Now, as you can see, this is the last slide for acetaminophen. You can see there that it goes down to 7 to 10 grams. Just know that 7 to 10 grams, as you can see, is in children. Okay, so lower doses in children. And the reason for that, if you remember from what we talked about earlier, the 2 years old all the way through 12 years old, they actually metabolize faster. But that does not mean that you're getting rid of the drug faster. What that means is that you're actually producing more toxins. If you know what I mean. That's why the doses are lower to get to an acute liver failure. So just know that from 10 to 15 grams is for adults. For 7 to 10 grams is for children, and the reason for that is that they metabolize faster, and they are producing NAPQI a lot faster, and they're depleting glutathione a lot faster. Okay. And then this is just what we talked about earlier. At low doses, acetaminophen goes through sulfation and glucuronidation, but at higher doses, this is the one that I've been talking about for the longest time, NAPQI. It eventually causes cell necrosis and also depletes glutathione. Okay, so those are the two main mechanisms by which NAPQI will cause hepatotoxicity. And then this we can skip. This is very straightforward, and we'll go through it as well when we talk about complications. Key points of drug-induced liver disease. Know the list that we went through. Okay, make sure that you understand that list, how they work as far as the hepatotoxicity is concerned. Make sure that you know the reversal agent to at least valproic acid and also your acetaminophen. Okay, so just know the N-acetylcysteine and also your carnitine for valproic acid. Remember what is going on as far as what's causing the hepatotoxicity for the most part. Usually for valproic acid or drugs that are lipophilic, they will impair fat oxidation. And there are other drugs that are idiosyncratic, like isoniazid, for example. Okay, and that's pretty much it. Any questions or concerns about this presentation? This presentation is very straightforward. He just has a lot of random information here. What I would focus on, honestly, is the list of drugs that he presented, the pathophysiology by which DILI, or the drug-induced liver toxicity, take place, and then you should be fine with Dr. Sun. So then we can move on to the fun part, which is actually cirrhosis, which is the clinical part of it. So let me just go back to this. So before we move on, I wanted to show you a video first that will help you understand what we're going to go through. Oh, here it is. It's 5 minutes, but we'll cut it shorter. Okay, we can do that. See. So just pay attention to what arteries and veins are included with the liver. So as you can see, you have your hepatic artery. She's just talking about different arteries and veins. Just remember that veins they're nutrient rich, but they have low oxygen, and then the arteries, they are rich in oxygen but low in nutrients. But look at how that will play a role in the metabolism of the drugs. In addition to that, look at the bile. So look at the bile ducts that are associated with the liver. So it's part of that as well. So when you have a bile obstruction, you also have a disturbance in your hemodynamics, okay, because they are associated with. That's called the lobule. That's where everything takes place as far as the different metabolism. So I think the important thing about this video is to show you why, when you have portal hypertension, what are the complications that you will see that are associated with liver disease. So portal veins are there, hepatic artery, and the bile ducts. So all three of them are closely linked to each other, which is why when you have, like I said, when you have an issue with bile duct, you will also have an issue with your blood flow in general. I think, yeah, that one. I had another one that was better. Okay, so this is the most important part. So scar tissues prevent the blood flow from going from the heart into the systemic circulation and vice versa. As you can see, you have two vein or one vein and one artery rather that are connected to the heart and to the systemic circulation. When you have scar tissue, what happens is that you're pretty much blocking the flow of the blood, and so you eventually develop portal hypertension. Okay, and then from there we'll see the other complications. So I just wanted to show you kind of like a visual representation of what's really going on and what are the relationships between the bile duct and why we talk about cholestasis and liver disease and so forth. So hopefully that gave you a better understanding of that. So let's talk about the complications of liver failure. She's very straightforward with her questions, Dr. Wantokis, and this particular, she has a passion for nutrition and also liver disease. So make sure that you take this particular, these two presentations, you focus on these more than Dr. lectures because they're gonna take a lot of questions from these two presentations. Okay. There are two guidelines that we use. There's the European guidelines and the American Association for the Study of Liver Disease. This is the one that I would focus on for the purpose of the exam. We don't use this one because we're not in Europe. So, but you do use, you can compare and contrast both of them. There are drugs here in Europe that are not available in the United States, so that's why it's better to use the AASLD. So cirrhosis, we talked about it already. It's an end-stage condition. So you start off with liver damage. You can have acute liver failure, and then you progress to a situation where you have scar tissue, and that's the most important thing. For cirrhosis to happen, you need to have scar tissue at that point in time. She is talking in the slide about the different functions that the liver is responsible for, and we already talked about that as well. So there are common causes associated with hepatic disease. Toxins is one of them. So alcohol, acetaminophen, we talked about it already. So DILI. Infections like hepatitis, autoimmune hepatitis as well, B and C. And then non-alcoholic fatty liver disease, NASH, is it stands for non-alcoholic steatohepatitis. So this is every time you see the word steato means it has to do with fat. Okay, so in this case, it's fatty liver. So there's a big deposit of fat that will inhibit the function of the hepatocytes to metabolize drugs and to detoxify toxins, and so eventually you develop cirrhosis. And then it could also be hereditary or genetics, so hemochromatosis and Wilson's disease. Both of them, just know you have to know a lot about these two diseases. Just know that hemochromatosis is a buildup of iron in your in your bloodstream, which will deposit in the liver. And then Wilson's disease is copper, is what is being deposited. So those can lead to also hepatotoxicity. Stage of liver damage. You have the fatty liver here, so you start with a layer of fat, and then you eventually develop liver fibrosis. So the liver fibrosis is just scar tissue that's forming, and eventually you develop cirrhosis, which is pretty much whatever has been fibrosed or scarred, that area is no longer functional. Okay, so eventually, what do you think is going to happen to a patient that has cirrhosis? Like, what would be the end therapy for that patient? A transplant, so liver transplant. And then we use a particular staging or calculation, which is called a MELD score, to determine if the patient is a candidate for transplant. So that's the only thing that you need to know about the MELD score is that it's used to stage patients. It goes from 0 to 40, and it tells you the mortality within 3 months, and is used again for staging patients for liver transplant. Damage of alcohol abuse on the liver. So again, remember that ethanol is a hepatotoxic, and it also can lead to reactive oxidative stress as well, or species. So it's pretty much the same as having an acetaminophen overdose as well. And then we'll go over all. This is I think it's a very good summary of what we're going to cover pretty much. We're going to cover ascites. We're going to cover varices, the variceal bleeding. You're going to have them mostly in your low pressure points. So it's your esophagus and also your stomach. Okay? Mainly esophagus more than stomach, but you can also see them in the stomach. You could have edema because when you have liver, when you have cirrhosis, remember that you don't have the flow of blood circulating appropriately. So some of the blood is actually staying in this extremity. So you develop peripheral edema. The sexual characteristic changes we talked about because of has to do with your fat distribution and your cholesterol buildup. We talked about hepatomegaly and splenomegaly. Splenomegaly is the spleen is right next to the liver as well, so it will also, because you have a flow that's blocked, your liver has to go somewhere, so it actually goes to both to your spleen and to other places as well. So jaundice is just a yellowing of the skin. It's just increased bilirubin because you're not secreting it appropriately. And then spider angiomas, we'll talk about that as well. Anemia, thrombocytopenia is very important. So platelets are also, the liver is also responsible for destroying platelets as well. So you can have thrombocytopenia because of hepatic disease. Coagulation disorders, because clotting factors are produced in the liver, just like albumin. We talked about that as well. This is a spider angioma. And just so that you have a better understanding of what that is, it's basically kind of like a virus. It's just capillaries that have been ballooned up because of the flow of the impaired flow of the circulation. And so again, it's just swollen blood vessels that you will see. Very, very characteristic of the pathogen. So that's something that I would remember, the spider angioma. And then you also have these two nail changes. The nail changes, if you want to write it down, the first one is I don't even know how to say it, but it starts with the M. And what that is just white lines on the fingernail, which actually represents low levels of albumin. Okay, so that's why you see the white lines. So it's basically this picture here is the representation of the Murex nails. The Terry nails is just a ground glass appearance, and the reason for that is because of an alteration in the vascularity. And again, it's because of the circulation that's been impaired. So in the picture, this is Terry's nails right here. As you can see, ground glass appearance, and then the Murex nails is just the white lines, and it's due to low albumin levels. Ground glass, yeah. So you can't really, it's like opacity. So you can't really see. It's not clear. Um, Gynecomastia we talked about, testicular atrophy, and jaundice, which you'll see later on. Laboratory tests, ALTs, ASTs. Now, just like with renal, chronic, we've talked about this already, chronic hepatitis patient or chronic liver disease patient, you could see ASTs and ALTs normal. Okay, so that may not be a good indication for chronic hepatitis or chronic hepatic disease. For acute, you would see an increase in ALTs and ASTs. But so basically, it's just due to an impaired vascularity with the Terry's nails. And then the other one, the Murex, is because of the low albumin. So again, going back to the ASTs, ALTs, they're just enzymes that are in the hepatocytes. So the more hepatocytes that you kill, the more enzymes you will be releasing in your bloodstream, right? So in an acute situation, you will kill them quicker. You will see a spike in your ALTs, ASTs. That's why you have an elevation. Usually between three, this is a rule of thumb, 3 to 5 times the upper limit of normal is what will um, would be enough to discontinue a drug that's a hepatotoxic drug. Okay, so between 3 to 5. So just know that the normal ranges of ASTs and ALTs are between 20s and 40s, between 10s and 40s rather. So if you multiply that by 3, we're talking about 150 to 300 would be the 3 to 5 times the upper limit. Very, very important. I would highlight this right here: alcoholic liver disease. So you may see a case where you actually need to do this very simple calculation, and this will confirm that this patient, the cause of this patient's cirrhosis is alcoholic driven. It's not hepatitis or it's not anything else or drug induced. It's actually alcoholic. So when you have ASTs over ALTs that are 2 to 1 ratio, that's an indication of alcoholic liver cirrhosis. So that I would know as well. We talked about the MELD score. You don't have to know this slide, or you don't have to know this calculation at all. Just know what the MELD stands for. Again, it's a survival prediction, and it's utilized in transplant planning. That's it. And it pretty much tells you your survival rate within 3 months of having your end-stage liver disease. Now, this one I would kind of know at least what each of the different Child-Pugh scores mean. So it assesses prognosis of liver disease and survival rate. It's scored 0 to 15, but the important thing is that we use this to dose, okay? So we have 2 different systems for staging liver disease. You have your MELD and you have the Child-Pugh score. But for dosing purposes, you need to use the Child-Pugh score, okay? So nowadays with medications, they're putting on the package insert, just like with renal. You know, if you have creatinine of less than 30, then the recommendation is to reduce by 50% or whatever. But now they're including hepatic as well. So they're actually including Child-Pugh scores, B's and C's, then you want to do this or that or discontinue the drug. Okay, so what are the criteria that we use, or I guess the variables that we use for Child-Pugh score that you should know? So you have to know the 5 criteria. Ascites is 1, encephalopathy, bilirubin, albumin, and prothrombin time. You don't have to know the cutoff values necessarily, but you do have to know what the Child-Pugh score utilizes for the calculation to take place. Okay, there are 3 categories. C is the worst, A is the best, B will be in the middle. C is usually, I associate C with cirrhosis. So usually it's cirrhosis due to alcohol, and you'll see that later on when we go through the staging. Cirrhotic complications, we kind of talked about all of these, so we can skip it. Just remember where the liver is. As you can see, I think this slide actually makes more sense now. If you can see the heart and you can see where the aorta is and how it bifurcates to the liver, then goes into the systemic circulation. The hepatic portal vein is where, when you have portal hypertension, that's where your blood pressure goes up. Just keep in mind that when you have portal hypertension, that doesn't mean that you have hypertension. You could have a normal blood pressure, but still have portal hypertension. Okay, so let's talk about hepatic encephalopathy. So hepatic encephalopathy is basically a neuropsychiatric abnormality. It is partly reversible if it's addressed on time. And we're gonna go over all the drugs that you need. Very simple, very straightforward. The first line for hepatic encephalopathy would be lactulose. If lactulose doesn't work, then we can use rifaximin or Xifaxan. And then there are two other medications that you can use. There are antibiotics, neomycin and metronidazole. Why are we using antibiotics to treat hepatic encephalopathy? Like, what is the reasoning behind using antibiotics? Well, that could be the possibility, but not necessarily with the correlation with hepatic encephalopathy. So if you remember, and this is why it's important to understand the pathogens behind it. So the reason why you get hepatic encephalopathy is because this is I think the main point to remember for HE is they have an increased level of ammonia. At least that's the biggest hypothesis that they use, right? And if you think about it, you have bacteria in your gut they are producing ammonia as well. When you have your liver that's not functioning, the ammonia normally your liver detoxifies the ammonia that's produced by your bacteria in your gut. Okay, if your liver doesn't work, so what do you think is going to happen? So the ammonia is going to go up even more. So then you're using antibiotics to kill those bacteria so that you can kind of balance out the level of ammonia, okay, in your system. So that's the reason why. Lactulose, on the other hand, it's not a antibiotic. You know that. It's used for what? Normally, lactulose. What is it used for? Yes, yes, it's used for constipation. Yes, so it's used for constipation, so you get diarrhea, right, from it. So what you're doing is it's a binding agent as well. It's a disaccharide, right? Lactulose, and it binds to the ammonia. Keep in mind that your ammonia is going to stay mainly in your gut. So you need something that is not absorbable, which is lactulose. It does not absorb into your systemic circulation. It stays in your GI, and it basically sweeps everything, cleans up the GI and gets rid of the ammonia, and then goes to your feces and nothing. Okay, so that's the way it works with lactulose. The reason why it's better as a first line is because one is cheap. People, want to use it more than the other medications, and two, because of the very minimal side effect profile compared to the other ones. Now, metronidazole and neomycin are the other two options that you have available. Now, this is the problem with hepatic encephalopathy. Once you have hepatic encephalopathy, okay, or you are high risk for hepatic encephalopathy, then you want to start medications and you want to continue indefinitely. Okay, so when you're using metronidazole or neomycin, those drugs long term, you have really bad side effects. If you remember from last year, one of the biggest side effects with metronidazole is peripheral neuropathy. And so long-term use of metronidazole can develop it's irreversible peripheral neuropathy, also metallic taste, and it's just a pain to take metronidazole because you can drink or you can do anything. I mean, not that cirrhotic patients should drink, but you shouldn't mix them. So that's the reason why metronidazole and neomycin are last line for hepatic encephalopathy, is because they're not appropriate for long-term use. Okay. Clinical presentation, very important. So asterixis, remember, asterixis is a flapping tremor, okay? And it's again due to the fact that because you have a high level of ammonia, it goes straight into your blood-brain barrier, okay? And then it starts making all sorts of funky things in your blood, in your brain. One of the things that you will see is your asterixis, so it's just flapping tremor. In addition to that, you can see Babinski sign, which is what you're seeing there in the picture. When you use a blunt object to, I guess, touch the sole of your feet, usually the response would be toes go down, so they flex, right? But then for when you have the Babinski sign, or when you have hepatic encephalopathy rather, the Babinski sign, they actually go up, the toes go up. So that is a very quick assessment to determine if the patient has hepatic encephalopathy. Now keep in mind that this is not that gold standard for diagnosing hepatic encephalopathy. It's just a combination of things. Ammonia level, okay, in addition to the Babinski sign, in addition to asterixis. Hepatic encephalopathy has 4 stages, so we're going to base it off of the progression of mental mental clinical presentation that you use. Eventually, patients can lead to can become comatose, and that will be the last part of the hepatic encephalopathy, and they die. So there is a high risk of mortality associated with hepatic encephalopathy. And then the last part of this is just the classification. So this was a little bit confusing for me when I went through this, but I hope that I will be able to clarify. There are three types, and there are also grades as well. Okay, we use the West Haven criteria that has the four stages with four numbers, and then we also use the types. So we use two different types of scoring system to classify hepatic encephalopathy. The type, this is the easiest, or the thing that I want you to remember. The type is based on the, the cause of your hepatic encephalopathy. So type A is for acute. So acute liver failure. Type C, I told you guys, C for cirrhosis. That's the most common one. And the symptoms you will see are usually Babinski signs and asterixis, and also elevated ammonia levels. Type B would be in the middle. So something like non-cirrhotic portal systemic shunting. Okay, so I'll be in between. I don't think that you ask questions about type B, mainly type A or type C. Okay, so now that's the category for hepatic encephalopathy based on the onset or the cause of liver failure. Now there are four stages. Now the stages are based on the symptoms, okay, on the clinical presentation. And as you move forward from one to four, four will be the worst, and one will be minimal signs or minimal symptoms. So MHE stands for minimal hepatic encephalopathy. The fact that they use the word minimal does not mean that you do not want to treat. Usually for high risk patients, you still would want to treat with lactulose for minimal. And then you would start seeing, and this is the grade levels here, slight mental slowing down. Grade 2 would be a little bit more aggressive, so you would have fatigue, apathy, lethargy. Grade 3, you can have somnolence, and then grade 4, you get into a comatose stage. So those are all the things so they're based on neuropsychiatric symptoms, the grades. The types, they're based on the cause of your liver failure, okay? And then the last part of it is the covert versus overt. Covert means that it's just a term that groups the symptoms, so the grades. Covert follows minimal hepatic encephalopathy in grade 1, pretty much. So in other words, covert is just not an emergency situation, if you want to think it like that. Overt, on the other hand, is the umbrella term for grades 2, 3, and 4. So those would be considered more life-threatening situations. So that's when you want to treat. There are studies, and it's very controversial. There are studies that show that you always want to treat overt. You may not always want to treat covert. Okay, so those are the two differences there. So I hope that makes a little bit more sense, because when I went through this, it did not make sense at all. Now the other thing is, you don't go from, like, you don't try to see, like this order in a horizontal line. It doesn't work like that. She put everything there to show you that those are all the things that we take a look at for staging HE. It doesn't mean that if you're stage A, you're only going to be 1 or MHE. You know what I mean? That's not how it works. You could be, the way it works is this. I have a patient that is a cirrhotic patient, so it will be type C. The patient has somnolence, and they're kind of, the closer to comatose. So they're 3. So obviously they're overt. And then the time course, whether it's an episode, recurrent, or persistent. So you choose the ones that based on your categories, but it's not like because you're C, you're automatically going to be 3 or 4. Okay, so that's something else to keep in mind. We talked about all of these already. The drugs, so benzos, narcotics, alcohols, they can also precipitate hepatic encephalopathy. Hemorrhage, so variceal bleeding is also a risk factor for hepatic encephalopathy, and we'll see later on. In addition to that, something very important is large volume paracentesis. So paracentesis is something that we actually do to patients that have refractory ascites, that have an issue with the sodium retention and flow and fluid retention, and they need to get more fluid out of the abdomen area. So large volume paracentesis can also precipitate hepatic encephalopathy. Diagnosis, we talked about the gold standard is the West Haven criteria, and again, is based on the 4 stages that we talked about, and then the ammonia level, as well as the Babinski signs, the asterixis will also contribute to the diagnosis. Sorry. Okay, we can skip this. So who gets treated? Covert versus overt hepatic encephalopathy. I told you guys overt for sure has to be treated. Covert, it depends on the situation. It's more of a individualist approach. Prophylaxis. So this is important because she's going to ask you prophylaxis for pretty much everything. So prophylaxis for primary, not typical. Okay, so if you haven't had hepatic encephalopathy, you have high risk of hepatic encephalopathy, it's your call whether you want to start prophylaxis or not, but it's not recommended for all patients. If you have had secondary, so you've already had hepatic encephalopathy experience or episode, then you want to prophylax, and that would be definitely usually with lactulose. And we talked about all these lactulose plus rifaximin, probiotics, and then last but not least, metronidazole and neomycin. Any questions about hepatic encephalopathy or issues with regards to that? That you okay. Sure. Yeah. Is that right? Oh, it causes a reversible peripheral neuropathy, and so in addition, and also metallic taste and all those things. So the reason why they're last line is because they're not good for long-term use. Metronidazole is typically used for like C. diff or intra-abdominal infections, so they're not. It's not common to use long-term. Okay, so let's talk about ascites. This is basically buildup of fluids because of the hemodynamic instability due to liver cirrhosis for the most part. So basically, it's the belly area is going to be distended and pretty tense as well. So as you can see there, you can actually get a lot of fluid out of it by doing the paracentesis. It's a needle that goes straight into the abdominal cavity, and then you pull off liquid. This is a very she loves ascites, so make sure that you understand what the pathophys is of ascites. What's happening is most of the time is a consequence of portal hypertension. You have portal hypertension, usually is greater than 10 to 12 millimeters of mercury will be your portal hypertension or higher. Um, because of the fact you have portal hypertension, remember, if the blood is constricted, right, to an area, it's going to go somewhere else. So it goes straight to your spleen. That's why there's an increase in systemic splenic dilation. Because you have vasoconstriction of your veins and arteries in your liver, then you will have vasodilation in your spleen. So that's the first step, is an increase in systemic splenic dilation. The reason why this is very important is that one of the drugs that we use for ascites is, and eventually for variceal bleeding, is octreotide. Okay, and octreotide will cause vasoconstriction. Now you may think, why is it that we're using vasoconstriction or vasoconstrictors when you have portal hypertension? Octreotide is actually very selective for the spleen. So it will vasoconstrict the spleen. It doesn't do anything to the actual portal vein. Okay, so that's why we use octreotide, which is a somatostatin analog. Okay. In addition to that, because you have an increase in systemic splenic dilation, you have a decrease in arterial blood volume. Because remember that the spleen is the one that's responsible for what? What does the spleen do? Like, what's the function? What's that? Yes. So how so? Yes, so it's a filter, exactly. So it filters not only foreign objects, but also takes care of platelets and erythrocytes, red blood cells that are, dead pretty much. The spleen will take care of, will clean. So it's a filter, very good. So you have a decrease. So basically, what I'm saying is that the arterial blood, that's the one that is rich in oxygen, rich in red blood cells, they are filtered through the spleen. There's a decrease in that volume. By having a decrease in blood arterial blood flow, what is the mechanism by which your body tries to compensate for when you have hypotension, when you have low systemic blood flow, which is the case, which is this case. You have decrease in arterial blood volume. Obviously, you're gonna have what, low blood pressure, right? Because you have a decrease in arterial blood volume. So what will be the mechanism that compensates for that? because that's the reason. I mean, she's gonna ask me this question. That's why I'm trying to kind of get it from you guys. So if you increase the heart rate, that would be good, right? So your heart starts to pump faster. That's good. But then, what other mechanism will your body go through? Because eventually the heart cannot pump it if you don't have blood. So you need to increase that volume. So what will be the compensatory mechanism by which the body increases that volume? And she will ask you this question. So especially when you go to Bay Farm, she will ask you this question. Okay, so you have vasoconstrictors, good. So norepinephrine, those types of things. What else? Another thing that you haven't talked about. So would you use diuretics if you have low blood volume? So it will be the opposite, right? So you're closer. So think about that. Mhm. So what is the system that? What is this? I think you're getting there. What's the system that's responsible for retaining fluids? If that's what the route. Which one? So you can have antidiuretic hormone, yes, and what else? So we use lisinopril, we use ACE, we use ARBs, we use so angiotensin. So the RAS, right? The RAS is responsible for renin, angiotensin system, right? So the RAS is responsible for sodium and water retention. The reason why I tell you this is because we use two drugs to get rid of ascites. We use spironolactone and we use furosemide. Furosemide is responsible for getting rid of the fluids through the kidneys, but spironolactone is responsible for shutting down the RAS because spironolactone is an aldosterone antagonist, if you remember. So then that's the reasoning behind it. You have low blood volume that will activate your RAS, and by activating the RAS, you have sodium retention and fluid retention, and you get big. You know, your belly gets big because you're retaining a lot of fluids and a lot of sodium. By shutting down that RAS system, then you can get rid of the ascites. So that's the dual mechanism by which you use spironolactone and furosemide. You, you use them together. So you want to remember the dose of both. It'll be on the exam. So you guys know 40 of what? Furosemide? Mm-mm. Keep going up. It's up. It's 100, yes. So 100 milligrams of spironolactone for every 40 milligrams of furosemide. You can go 4 times would be the upper limit or the max. So if you multiply times 4, you have 400 milligrams of spironolactone and 160 milligrams of furosemide. That will be the highest. Now, what we're doing here is we have a patient that just recently started having abdominal distension, issues with their abdomen, and then eventually they develop ascites. This is only applicable for patients that are starting with ascites. We're not spironolactone and furosemide treatment is not for refractory ascites. What that means is that you can't really change what the body is doing, or you can't manipulate it to the point where once you get rid of the fluid with the paracentesis, it goes back up like within 30 minutes, which is crazy. And at that point in time, the patient is very most likely needs either a TIPS procedure done, which we'll talk about, or a liver transplant at that point. And paracentesis is used for symptom relief. That's very important. So you have a patient that just can't, they're short of breath because they have this big belly. They get a paracentesis done, and then they are started on the spironolactone furosemide combination to defer or to stop the progression of ascites in the future. Okay, so that's the reason why. And then eventually, the last part of the puzzle is the renal vasoconstriction, right? So that again, it increases blood pressure. Okay, so this is very important. She's going to ask you that question for sure. We have it here: resultant activation of the RAS system. Okay, so make sure that you remember that. So cirrhosis here, what's important about this slide is that you can get hyponatremic. It's a falsely low hyponatremia because of the amount of fluids that you are retaining. Okay, but you eventually get hyponatremic because of the fact, and this is really important, because of the fact that you have vasodilation in your spleen. If you think about it like physically, physical aspect of it. When you have vasodilation, you're pushing other organs, and you're pushing, and this stability, hemodynamically speaking, changes as well. So by having splenic vasodilation, you also eventually develop something called gut bacterial translocation, which means that your bacteria that's supposed to be in your gut, you're actually pushing it somewhere else because of the amount of fluid that you have in your system. And where does that bacteria eventually go to? To the ascites. Okay, so it actually stays in your abdominal cavity, but instead of staying in your gut, because of the third spacing, because of the amount of fluids that you have, that gut is actually the bacteria is translocating to the ascites fluid. And eventually, what that means is that you develop SBP, which is spontaneous bacterial peritonitis. Okay, but it's because of that. This yellow rectangle, whatever, the SAAG, that's the serum albumin ratio. When you have albumin in your acidic fluid, okay, and it's more than, and you have to memorize this number, it's more than 1.1, that is an indication for portal hypertension, okay, which is what we're talking about, pretty much. Okay, so does that make sense as far as like how you get SBP? What is the pathophys behind ascites, and why is it that we use spironolactone and furosemide to treat it? Does that make sense? Okay. Last part of the presentation for, in this case, we're going to talk about SBP specific. Well, I think this is ascites still. I think that should be a mistake there. But one of the things that you're going to see, this looks like an alien baby here, but it's actually something called caput medusa. Okay, and it's basically your veins in that area. Abdominal veins are pretty much swollen, very similar to what we talked about with the spider angiomas. Remember that the spider angiomas are going to be in your derm area for the most part, superficial. But this one is more of a backup of the fluids in your abdominal cavity. So you're going to see the caput medusa. So this is a very characteristic of ascites. Okay, the caput medusa. Also, you have reduced appetite and increased shortness of breath, and we talked about it as well because of the fact that you have it's similar to heart failure if you think about it, right-sided heart failure. Look at this here. It's just disgusting. Look at the belly button, and also how the paracentesis takes place. Look at how they're taking the fluid off of the person. Eventually, if you have a person that has refractory ascites, once you finish with the large volume with the paracentesis, it balloons up again within 30 an hour, the same day. So then at that point, you have to do multiple paracentesis procedures every day, or every week rather. So to the point where, it compromises the quality of life of the patient. The other thing that we do is an abdominal ultrasound to determine how much fluid you have and how much you need, whether you need a small volume paracentesis or large volume paracentesis. And then we talked about the serum ascites, albumin gradient. So if you have more than 1.1, that's an indication for portal hypertension, and that's very important for the exam. Okay, so we're almost done. Let's talk about the management. So again, we're going to treat the underlying disorder. If it's alcoholism, we're going to do alcoholic withdrawal treatment. We're also going to restrict the sodium to 2 grams per day. We're going to restrict the fluids also. And then we are going to use diuretic therapy. We talked about spironolactone and furosemide. Very important, I think we had a question about this. If you have your serum sodium is less than 120, okay, which is considered hyponatremia, even if it's falsely low, or symptomatic hyponatremia, then you want to restrict fluids at that point in time, okay, until you until you get to that balance again. So that was a question on the exam. We talked about the max doses there, and then this is the process for the treatment. Eventually, you can do TIPS procedure, and then a liver transplant. We'll talk about TIPS later on. If gynecomastia is present, which is very commonly seen in patients with liver cirrhosis, then you can use another potassium-sparing diuretics or aldosterone antagonists like that. Well, these are not aldosterone antagonists. These are more potassium-sparing diuretics like Eplerenone, Amiloride, or Trangia. Complications of diuretics. This is a very important slide, so I would remember all of these. If you have they're very straightforward. If you have a potassium of less than 3, you stop furosemide. If you have a potassium of greater than 6, you stop spironolactone. So just remember that you have both the patient of both spironolactone and furosemide. If for some reason the potassium goes lower than 3, you have to stop furosemide and you keep the spironolactone though. If you have a greater than 6, you stop the spironolactone but you keep the furosemide. Okay, that's something else that she asked on the exam. And then the other thing that's important here with this slide is the volume that's removed. If it's less than 5 liters, that's considered a small volume paracentesis. If it's greater than 5 liters, it's considered a large volume paracentesis. For large volume, you have to give albumin, and it's the ratio or the amount is 6 to 8 grams per liter of fluid that has been removed. The reason for that is that if you do not give albumin, you eventually develop circulatory dysfunction, which will eventually lead to hepatic encephalopathy and hepatorenal syndrome, which is pretty lethal actually. So you have to give albumin. Albumin, remember, it's a volume expander, right? If you remember the crystalloids and the colloids, albumin is a volume expander. So what it's doing is it's opening up your blood vessels, so that when you are removing that much, 5 liters is a lot of fluid that you're moving at one time. You want to make sure that your body is compensated in a appropriate way. By not giving albumin, your body pretty much shuts down and goes into hypovolemic shock sometimes, and then you can get also the hepatic encephalopathy and the hepatorenal syndrome. Very important concept to remember as well. The TIPS procedure, just very quickly, she didn't talk too much about TIPS on the exam. We didn't see a lot of TIPS procedure, but it's basically it stands for trans intrahepatic portal shunting. Remember the shunting that we did, or the septostomy that we had to do for heart failure? Same thing goes with this. What we're doing is we're putting a stent, as you can see there. See the hepatic vein, the portal vein. We're putting a stent to reduce the pressure, okay, to lower the pressure. The mortality with TIPS is very high, and complications as well. One of the biggest complications is actually hepatic encephalopathy. So you do a TIPS procedure in a patient that that has a MELD score that the patient will be a candidate for liver transplant. Okay, this is a very temporary stage. It's not something that will solve the problem. And again, you want to do this to patients that are either awaiting a liver transplant or they're very close to going into the liver transplant list. Very important. And then the contraindication you have to memorize, okay? This she did ask us. So bilirubin of 5, INR of greater than 2, CHOP-U score of 11, which would be CHOP-U of letter C. And then an HE grade of 2, which would be overt hepatic encephalopathy. So this you have to remember for contraindications for TIPS. And then the last part is your spontaneous bacterial peritonitis. Very straightforward. When you take out the paracentesis, the fluid, you send it off, and then you want to check for PMNs. If you have more than 250, you treat. If you do not have more than 250, you do not treat. The only reason why you would treat is if you have symptoms of infection, signs and symptoms of infection. So let's go through it real quick. SBP, it could be due to variceal bleeding. It could also be due to ascites. We talked about it already. Or also previous history of SBP. And then we'll go over the drugs that you can give, and that will be the end of this presentation. So mostly gram-negatives and gram-positive cocci, gram-negative bacilli. You could also see anaerobic organisms as well. But the important thing about SBP is this right here. PMN of greater than 250. That number you have to memorize. If you do the paracentesis, right? You do the paracentesis and a little bit of the fluid you send to the lab, and then you get a PMN of greater than 250, then you want to treat. It doesn't matter if you have signs and symptoms of infection, you still want to treat because you're high risk for SBP. Okay. Most of the time, the culture is going to come back negative. So you want to go by the PMN. If you have a low PMN, but the patient has signs and symptoms of infection like fever or chills or whatever the case may be, then you still want to treat the patient. Okay. This is what pretty much we're talking about. If you have PMN of greater than 250, you want to treat, and then you usually will use third-gen cephalosporins for the first time. This is very important. First time occurrence of SBP, you want to use third gen cephalosporins. If it's not a first time, if it's a second time, then you can use something else, and we'll go through it. You can use either fluoroquinolones or Bactrim, okay, for empiric therapy. Um, if you don't have the 250 for the PMNs, but you still have signs and symptoms of infection, you still want to begin empiric therapy for SBP. Okay, um, and that's pretty much it. The course would be 5 days regardless. So just remember that the course of therapy is 5 days. And then the last part of this is just the what the empiric therapy versus secondary versus primary. This is very confusing as well for us because of the way she worded it. So I'm gonna walk you through it real quick. Empiric therapy is what we just talked about. You have a PMN of greater than 250, you start empiric therapy. Okay, if you have a PMN that's less than 250 but signs and symptoms of infection, you start empiric therapy. So that will be empiric therapy. The patient doesn't necessarily have SBP, okay, but you are protecting the patient against SBP. These are all the drugs that you can use: third gen cephalosporins, um, fluoroquinolones, or your back. Secondary SBP prophylaxis without a GI bleed. So what that means is that the patient actually had SBP. The patient was treated for SBP, it was resolved, but the patient now you want to give prophylaxis, and this is without GI bleeds. Okay, so this is a patient that probably has ascites, okay, and they are at high risk of developing SVP. So you can do Cipro, Bactrim, or norfloxacin. Pay attention to the fact that there is no duration. So sometimes the patient is going to be on antibiotics indefinitely or for a long period of time. Okay, so that's why this is important. Patient had an SVP episode, and patient has a risk factor such as ascites, but no variceal bleeding. Okay, now the last one is primary SBP prophylaxis, and this is actually the patient has not had SBP, that's why it's primary, but the patient has two risk factors: ascites and diabetes. Okay, and then at that point, the duration is between 3 to 7 days, and you can do cefotaxime, ceftriaxone, Cipro, or that. Okay, so just remember that. For second SBP, you cannot use third gen cephalosporins. Third gens are mainly for empiric therapy if you have never had SBP before because of resistance. Yep, and that's pretty much it. Let me see here. Oh, in addition to that, in addition to SBP antibiotics, you also want to give on day 1 and day 3. Remember that usually it's going to be 5 days of therapy. Day 1 and day 3, you want to give albumin as well. And the reason for that is that SBP, they're all related with each other. If you have SBP, you're at high risk of hepatorenal syndrome. If you have ascites, you're at high risk of SBP. If you have variceal bleeding, have a high risk of SBP. So they're all connected with each other. So the reason why we're giving albumin is to protect against hepatorenal syndrome, which is our next complication we'll go through. Okay, so the dosing, bless you, the dosing is 1.5 grams per kg day 1, and then day 3, 1 gram per kg. The important thing is, and I think she asked this question as well in the exam, you want to dose albumin based on your body weight, total body weight at diagnosis, which is probably going to be high because you haven't done the cryostasis. Does that make sense? So you have a lot of fluids, and that's the way that you're going to use. Okay, you don't use the weight after diuretics. Correct. To use the largest, yeah. Perfect. And again, we're just protecting against circulatory dysfunction and hepatorenal syndrome is what we're concerned about. We're almost done. The other one is a little bit shorter, so bear with me. Any questions about what we've covered? I'm sure you will have questions next week, and I'll have cases for you guys to kind of practice. But this is good to you're ahead as far as at least you've listened to the information, so that helps a lot. Okay, so let's go through this quicker. We've already talked about portal hypertension, so you have an idea of that and what happens with the portal hypertension. Keep in mind that because of the portal hypertension, you have vasodilation of your spleen. So that's why you eventually have splenomegaly. Okay, where the spleen is. That makes sense if you think about how what's going on. You have high blood pressure here, so it's fluid is backing up to here. Okay, and because you have vasodilation, you have low blood volume, and then the RAS system kicks in, and so forth. The normal is 3 to 5 for portal hypertension. I mean, for normal, no portal hypertension, and we talked about greater than 10 to 12 for a diagnosis of portal hypertension. The therapy would be beta blockers, non-selective beta blockers. Okay, so that they're systemic. You have two options: propranolol and nadolol. Propranolol has more side effects than nadolol, and then they're also, as far as the compliance, you have to give it twice daily. So it does not make sense to have propranolol as a recommendation. I think the only thing is that propranolol is cheaper than nadolol. But other than that, as far as compliance, nadolol is once daily dosing and has less side effects. So why not go with nadolol? Indications for treatment of portal hypertension. This is very, very important. You only start beta blockers if you have the varices present, GI bleeding, okay, or a high risk patient that's about to develop variceal bleeding or varices. That's the only time they would start beta blockers. Okay. Again, they are. We talked about the goal or the number here. HVPG is greater than 10 to 12. Varices are present in about 50% of cirrhotic patients. So most of the time, cirrhotic patients will come to the hospital because of variceal bleeding. If you have a patient that comes in and they start throwing up blood, what would you think that is? That will be an indication of what? Of a GI bleed, right? Because it's upper rather than if you have it in the stool, then it would be bleed in your intestines, right, rather than in your upper GI tract. Esophageal is more than gastric, so you're going to see them more in the upper GI than in your stomach, the varices. So EGD is the gold standard. Basically, an EGD, and I actually saw this, it takes about 5 to 6 minutes actually to get it done, like the whole procedure. They take forever to prep up the patient more than the procedure itself. But basically, they put in like a camera, like a little camera at the tip. They go straight in there to the esophagus and then they look at the wall, the wall, the stomach area, and they're looking for bleeding. Okay. There's one thing that I wanted to add real quick. There's a term that she actually talked about, and it's the red whale marks. Red whale marks. If you see that term, that means that a patient either had varices and he or she was not treated for it. It's just basically what's left of a variceal bleeding episode. Okay, red whale. They're going to be in your esophagus or in your GI pretty much, and it's red because of the blood. Okay, so it's just what's left of a variceal bleeding episode. And that's important because you want to take that into consideration when you start prophylaxis, okay, or when you start therapy with beta blockers. If you see red whale marks, that will be an indication of a patient that has high risk. The patient probably have variceal bleeding. You want to start beta blockers in that patient. But the gold standard is an EGD. And again, we want to treat based off of size of varices. This is very important. So small is less than 5 millimeters. Large is greater than 5 millimeters. The therapy would be either beta blocker, okay, so we talked about that already, and also we use ligation, so EVL, okay, variceal ligation. And basically what we do is the varices is like a balloon, right, like an aneurysm. It's about to pop and about to release the blood. So what we do is we put a what is that called? When you the ligation, I don't remember the name in English, but basically like a rubber band is what they put, like a rubber band. So they put a rubber band right at the base of the varix so that it doesn't explode. Okay, so that's EVL. EVL has been shown to be just as effective as medications, but it may not have, or it doesn't have really the side effects that the medications can introduce to the patient. Okay, so that's something else to consider. Then we talked about the GI bleeds being a risk factor for SPP, so you want to treat it as well. So look at this here. You have cirrhosis, and then you have an EV development. So you have esophageal variceal development. You can see there that they go from small to large. Then you have your first bleeding. And so primary prevention would be when you have large varices, okay? You don't prophylax if you have small varices. That's very important. You only prophylax if you have large varices or if you see the red whale markers that we talked about earlier. Secondary prevention, you already had a episode of variceal bleeding. You want to go ahead and prophylax at that point. Okay? This is pretty much what we talked about, so we can skip it. Um, so look at this. Small varices present. So if you have small varices, usually we do not prophylax. But you only would utilize non-selective beta blockers in patients with small varices and Child-Pugh score of B and C, which is pretty much the worst, right? C would be the worst. Or look at that. If red whale marks are present on the varices, okay? So that means that um, it has had, the patient has had an episode of variceal bleeding or the varice is about to explode, even though it is a small varix. So at that point, you want to start beta blocking. That's why that's important to remember, okay? And then we also have the endoscopic variceal ligation, which is the EVL. And again, I said earlier, it is as efficacious as beta blockers. So sometimes they actually do EVL and they don't start beta blockers, and sometimes they do both. The only thing that I want to focus about this, we talked about the two drugs. We talked about the dosing. One of them is once daily, the other one's BID. We also talked about the drug events, the ADEs, and you know beta blockers, what they do. Just remember that the one thing is that we actually titrate based on heart rate. The heart rate is actually very low, and I didn't know this until I was reviewing this information. If you have a patient that has a heart rate of 100 and you have started the patient on propranolol 20 BID for prophylaxis of variceal bleeding, and you still have a heart rate of 100, you need to titrate that propranolol until you get to a heart rate of 55 to 60. So it's on the lower end of the spectrum, okay? But just remember that. If you don't have a heart rate that's low enough, then it's not doing anything, okay? Or it's not prophylaxing for variceal bleeding. So you want to have a lower, the heart rate goal should be between 55 and 60. Now, what would you do for variceal hemorrhage? Now that you have a bleed, you have to, it's a life-threatening situation, so you want to admit to the ICU. You should not use crystalloids. This is very important. So if you have a patient that comes in with variceal bleeding, you do not start normal saline or anything like that. You want to do blood volume resuscitation. So you actually want to replace the blood. You do not want to just give water to the patient, free water or normal saline. So what you need to do is most of the time you need to do transfusions, right, of red blood cells or plasma cells as well, or plasma transfusions as well. But in addition to that, you have two options as well. Your octreotide again shows up, and then your vasopressin. Both of them are going to help with the splenic dilation aspect, and we talked about it already, right? So your octreotide is more commonly used, and the reason for that is that it's more selective towards your spleen, and also you can use it for more than 24 hours. Your vasopressin, because of the side effects associated with it and the fact that it's systemic, you can only use it for 24 hours. Your vasopressin. So if the variceal bleeding is not resolved within 24 hours with vasopressin therapy, you have to switch to octreotide. So why not start with octreotide at the beginning and then continue on with for 5 days until the variceal bleeding is resolved. Okay, so I guess that's my personal, spiel there. But in addition to that, once you resolve the variceal bleeding, you have to start PPIs on the patient to prevent from stress ulcer for stress ulcer prophylaxis and to prevent gastric ulcers because you already had an episode of variceal bleeding. Okay, and like I said, we talked about octreotide and vasopressin. The mechanism of action you should know, and we already talked about it already. And then as far as the benefits, it can be used for more than 5 days. The other one you can only use for 24 hours. And then the other thing is that and this was a question on the exam, when you use vasopressin, it has to be in conjunction with nitroglycerin because it is a very powerful vasoconstrictor that it could eventually lead to ischemia, necrosis, and also hypertension. So you want to give with nitroglycerin as well. And the last part of this, we can do this tomorrow. But the last part of it is the secondary prophylaxis. So this was when the patient already had an episode of variceal bleeding, okay, and then now you want to start therapy. So you use beta blockers there. You want to combine with the isosorbide mononitrate for vasodilation, but it's very poorly tolerated and increases the risk of ADs. So she said not to worry about that combination because it's not recommended. So you want to use EVL plus beta blockers is basically what is recommended. Okay, and then the last line would be TIPS procedure, and that will be again for patients that are getting closer to a liver transplant. So too long, didn't read. The important thing is that varices can be present in all stages of cirrhosis. It's about 50% of the time that you would see varices in patients with cirrhosis. For prophylaxis, for primary, you haven't had variceal bleeding yet. It will depend on the size of the varices or whether you have red whale markers. That's why it's important to remember. Reduce the risk of rebleeding. Okay, medications primarily non-selective. So remember something very important because we've talked about a lot. For the non-selective beta blockers, we do not use that to treat an active GI bleed. Okay, if she asks you that question, it makes sense, right? The reason why we're using beta blockers is to prevent from the bleed from happening, right? If you have an active GI bleed, you do not start beta blockers. What you're gonna do is what two drugs we just talked about that we can use for variceal bleeding. Once you actually have the active bleeding, what are the two drugs that we just talked about? Which one? Well, PPI will be after it's been resolved. But there are two drugs that we just talked about that you can use for when you actually have a variceal bleeding. Octreotide, good, perfect. So octreotide would be for an actual variceal bleeding episode. What would be the other one that we kind of compared and we said that you could? Which one? Vasopressin, right? So that's only used within 24 hours. Very good. So then once the variceal bleeding is resolved, that is considered secondary prophylaxis. Then you start beta blockers. Okay. Hepatorenal we can finish tomorrow because it's not a lot, so we can just skip that one. Any questions about everything that we talked about today? Liver is going to be a big component of your exam. She's going to have a lot of questions about liver. Pediatrics, which is the next module, I think you will have. I think the exam is pediatrics and liver, right? Liver. So pediatrics is very straightforward in the sense that you have seen these things before, but she's going to introduce certain things that you need to know for pediatric population. That's it. So it shouldn't be that big of a deal. I would focus a lot on liver disease because it's something that she will ask a lot of questions about. And most of the questions that she has are going to be conceptual based questions, like pathophys. That's why I kind of stressed a little bit on, you know, how to understand how all these complications take place. So I hope that they are clear. I will have a review on like next week before the exam, so that once I know that you're focused on law, or once you are, done with law, then this will all click in. So if you don't have any questions, we can stop here and then we can finish with what we'll do tomorrow is we will finish hepatorenal syndrome, which is very straightforward, and then we will start the pediatrics, and I think the way, because you have 12 lectures that we have to go through. Okay, so we're almost done with 3. So I wanted to do 4 lectures tomorrow. Hopefully, we'll see. What I'll do is instead of going through each slide, I'm just going to tell you like the ones that you kind of need to focus on for Pete, and then we have Tuesday of next week to finish it off. So that's what we'll do. Okay. Any questions or issues or? Yeah, you guys, are you all IPP? You're done with IPP, right? Oh, you're still doing IPP? You're exhausted. 2 more weeks? Oh, you lucky bastard. You lucky bastard, yeah. Yeah, we didn't get the opportunity to do that at all. Yeah, but here's the thing, though. This is what I told